Welcome everyone to our IFAM seminar series. This week, we're presenting it in partnership with the Center for Epidemiology and Population Health. For those of you that are online, we just want to make sure that you're aware that we're not monitoring the chat. So if you have questions for the speaker, please use the Q&A function online and we'll do our best to answer them at the end of the talk. So it's my pleasure today to introduce Dr. Kazi, who is an associate professor of medicine at Harvard Medical School and the associate director of the Smith Center for Outcomes Research and director of cardiac critical care at Beth Deaconess Medical Center in Boston, Massachusetts. Dr. Kazi's research interests examined the epidemiology of cardiovascular risk factors, the real-world comparative effectiveness of novel strategies for preventing or treating cardiovascular disease, and the cost-effectiveness of clinical strategies, clinical and policy interventions. The overarching goal of his work is to identify scalable, cost-effective strategies for prevention and treatment that can equitably advance population cardiovascular health. So we're very pleased to welcome you here today on this St. Patrick's Day, and I appreciate you coming out.
Good afternoon, everyone. When Nori invited me, and thank you, Nori, for the invitation to speak, and I was like, St. Patty's Day, it seems like a good weekend to be in Chicago. Like, how crazy can it be? Wow, the city really knows how to throw a party. Thank you for having me. I'm hoping over the next hour or so, we can chat about some of my research, but I'm mostly going to try and present ideas. And so this is how I was thinking we would do the talk today. Oh, and please feel free to interrupt with questions. I actually prefer questions as we go rather than at the end, but I'm also happy to take questions at the end. No major conflicts of interest. And here's the tops of takeaway ideas that I'm going to present today. That innovation is going to be critical to healthcare in the US, but just as important as the innovation itself is the idea of how we're going to pay for it. And so financing innovation is going to be crucial to ensuring scalability and sustainability. Part of figuring out how much to pay for any intervention is knowing both the value of the intervention and reflecting on our own set of guiding values. And I'm going to talk a little bit about that. Sometimes the tension between value and values. And then lastly, I'm going to talk about if once we figure out the value, you can use that information to influence pricing, access, and equity. And the idea that I hope to present is that sometimes efficiency and equity are presented as dueling ideas in society. And at least in the world of cardiovascular medicine, they're far from that. There is not a tension between doing what's efficient and doing what's equitable. Because when you treat the highest risk population or you provide services to individuals at greatest, who might derive the greatest benefit, it is often also the most equitable thing to do in that population. And the converse is also true. I counted up this morning that at this point I have trained or worked in 19 hospitals. And what I found myself thinking is that often institutions that serve disproportionately disadvantaged individuals hide under this learned helplessness. That we can't do this, we can't afford this, we can't afford to offer these services because we don't have the resources of the big, shiny medical center. And the truth is that when hospitals do not focus on efficiency, they tend to compromise on health equity. Because even in the most dysfunctional health system in the world, AKA our health system, all of us are going to be able to get care. You throw barriers in the way of our healthcare, and we will be able to work around the barriers and get access to care. It's the individuals with the least resources in society who are disadvantaged most when systems are inefficient and fragmented. And so again, the main take-home message is like thinking about economics is not counter to thinking about equity. In fact, the only way to achieve equity is to have a laser focus on the economics of everything we do. So that's about it. That's all I'm going to talk about for the next 50 minutes or so. I figured I'd start with an introduction. I moved to Beth Deaconess about 7 years ago and helped grow this, what we call the Smith Center for Outcomes Research. It's a bunch of people who work on clinical and policy relevant questions. And I think that the secret to our success has been the 3 R's. We ask relevant questions, we use rigorous methods, and we create relatable narratives. And I think that last piece is super important. We've, for the longest time, given academics a pass that we can do good work and someone else will rely on will do the communication for us. And now more than ever, effective communication is a really important skill to develop both during training and during practice. And that has been a priority for us at the Smith Center. Nori touched upon this a little bit. My own research is like the goal is to focus on prevention in high-risk populations, prevention broadly defined. I work in the cardiac intensive care unit, so the advanced complications of cardiovascular disease for me are prevention. And so in order to answer in order to develop scalable strategies, one has to answer 3 questions. Who is at risk? What strategies are effective in the real world? And are these strategies scalable? And in order to do this, my research falls into 3 buckets. Who's at risk is mostly about understanding cardiovascular epidemiology, both in terms of risk factors and burden of disease. What works is about comparative effectiveness. And the goal is to go beyond descriptive analyses and think about more causal frameworks and thinking about, is treatment A truly better than treatment B in the real world? What are the parameters that makes one treatment better than the other? And the last is cost effectiveness, meaning if this treatment works and it targets a high-risk population, can we afford to scale it to maximize impact? And so here are some examples of the work in these 3 buckets. My apologies to folks, I presented some of these slides this morning, and so you're hearing it a second time. But the idea being, can we think about diseases not just in the longer term, but also in the more near term? So we're starting to look at COVID outcomes, for instance, in the Omicron era versus the pre-Omicron era, the kinds of analyses that you cannot answer using using trials. In the comparative effectiveness space, again, thinking about interventions that already exist, interventions that should exist, things that, again, you cannot answer using trials alone. That has been a focus of our comparative effectiveness work using target trial framework, and more recently trying to think about heterogeneity. So moving away from average treatment effects to like, are there subpopulations that derive the greatest benefit? And then a major focus of my work is cost effectiveness and understanding whether treatment A is more or less cost effective than treatment B. Should we spend, how much are we spending on insulin? It turns out we're spending a ton on insulin, but patient out-of-pocket costs have not really changed in a decade. And in contrast, some of the newer cardiovascular therapies, patient out-of-pocket costs are through the roof. So spending is through the roof and out-of-pocket costs are through the roof. All right, so that's who I am. Focusing now on this talk. Here are the 4 questions I'm hoping to answer over the next 40 minutes or so. Why should we care about the economics of innovation? And again, I'm going to talk about cardiovascular disease, but you will see that the ideas I'm presenting are relevant to any space that you work in. How do we quantify the economic value of innovation? And this is where I will like split off a little bit into talking about value versus values, and we'll do some thought experiments together. When is the right time to assess the economic valuation of value of an intervention? Is it too early? Is it too late? When's the right time to think about value? And then the last is, what are the positive repercussions of bringing an economic mindset to innovation and the focus on health equity? And again, I repeat what I said earlier. I think that in this crazy inequitable world that we now inhabit, the only way to advance health equity is by having a laser focus on economic value. And I'm happy to defend that position. All right, so let's start off. Why do we care about the economics of innovation? You've all seen slides like this before. I could change the title from per capita healthcare spending to per capita pharmaceutical spending. No matter how you measure it, we're clearly outliers in how much we spend on healthcare, twice as much as most high-income countries around us. And cardiovascular disease is a particular issue. And Nori used a really interesting term about obesity being a leading indicator for cardiovascular risk. And that's clearly, you can see here that we're looking at large increases in obesity over the next 30 years or so. And along with that, so 60% obesity, 60% hypertension, 25% diabetes in 2050, with large increases in cardiovascular disease, about 60 to 70% projected increases in cardiovascular disease. Again, the big focus here is on stroke. We're going to get older as a population. We're going to get more diverse as a population. And diversity is a good thing, but it also means that populations that have a higher burden of hypertension and poorly controlled hypertension form a larger proportion of our population. We see increased burden of stroke. And then parallel to all of this is the rapidly rising cost of cardiovascular care, a doubling and a tripling of cardiovascular care, a growth of about 1 trillion. And this is actually taking out the effect of inflation. So as a percentage of the GDP, this is a doubling of how much we would spend on cardiovascular disease over the next 30 years. Now, we're often told that, a big reason why we spend so much on cardiovascular care is because we do too many things. We do too many cardiac catheterizations, we do too many echoes, and somehow if we just chose wisely, things would go away. And the truth is that when you look at what factors account for most of the increase in healthcare spending, and if I were to give you all of these choices, yes, the population is aging and it's contributing to our increased spending. We do use some more expensive medications, but we really don't use that much more by way of medications or procedures. There are some exceptions. Notably, we do way too many MRIs for back pain, but that's more of an exception. The fact that I can tell you what that is, it's more of the exception than the rule. The driver of our healthcare spending is that we pay too much for the things we do. So in medications, procedures, our unit costs are too high. And I would posit to you that this narrative of overutilization has been repeated so often that now we take it to be the truth. Overutilization is an issue in some parts of the country. It is certainly in some health systems. But if we step back and look at the US population, our major problem is underuse, not overuse. We cannot get people access to the care we need. So averaged across the population, overutilization is not the narrative that's driving our costs of care. And again, this idea that cardiovascular disease as a driver, you would almost consider it a leading indicator of our chronic conditions. It affects us all, but it doesn't affect us equally. And so if you look at individuals who have low socioeconomic level defined by education or income and compare them with the rest of the population, you see a 2x the incidence of myocardial infarction and death from coronary disease, and only 40% of which can be explained by traditional risk factors. So there's a lot of other stuff that we need to address in the health system, in our healthcare risk, that isn't just a function of, inequity that we don't fully understand, that creates this cycle of poverty leading to cardiovascular disease trapping people in poverty over generations. Now, why am I saying that? I presented two ideas. Cardiovascular disease is growing. It's growing unequally, and it's very expensive. 3 ideas. And the point I'm making is our current approach is not scalable. So you have rapidly growing demand for services. You have unsustainable costs, largely driven by unit costs, but still an unsustainable growth in costs, and an inadequate supply of human capital and physical resources. And what do I mean by that? We say there are not enough cardiologists, or we say that there are not enough nurses for whatever function we're talking about. I agree. But I would also counter that we're not going to have enough cardiologists for the next 30 years. We are not going to be able to train ourselves out of this human resource deficiency. We are going to have to rethink how we deliver care, whether we like it or not, especially, I would say, for care for older adults, including stroke. And one of the things I didn't mention earlier is that if you look at costs projections for stroke, it's a 500% increase in the cost of stroke over the next 30 years. And it's because our population is going to get older and our unit costs for stroke care currently are very high. Now, fortunately for us, the face of innovation is also changing. So as we're thinking about these changing demands, our process of innovation is changing. What we think about innovation is changing. We used to just purely think of that first bucket. Let's find new drugs to do things better. But now we're rethinking there are fundamental discoveries in how we think about treatments. So very much in the experimental phase, but this idea that you could deliver a single dose of a medication that could have your cholesterol for the rest of your lifetime, it is a fascinating idea, because for the highest risk population, that could cut out a lot of high risk utilization. Similarly, for blood pressure medications, if one treatment could control your blood pressure for 6 months, that is an impactful way of thinking about blood pressure control and stroke risk, because as you know, blood pressure control adherence is a major barrier to achieving blood pressure control. There's doing more with the data we have, and the way I think about the role of machine learning in the future is it going to help with discovery? Is it going to help with delivery? Or is it going to help with drudgery? So is it the discovery of new ideas that are hiding in plain sight? Is it delivery of care? I go to clinic and someone is just typing up my notes based on the conversations. It allows me to see more patients. Or is it taking care of the mundane tasks that I need to do? And then, but the last piece is part of innovation, and this is expanding, and folks here and elsewhere are thinking about innovation more broadly. So we've, especially in cardiovascular medicine, we've gone through this phase where we were obsessed with new molecules, new drug discovery. That was what led to academic promotions. That's what got into the high impact journals. But thinking of innovation more broadly, like, okay, this is cool that you have this drug, but can we use community-based platforms in a way to deliver this therapy? We'll talk about, you've heard about the barbershop-based programs or church-based programs for delivery of care, and I very much think of those as innovation. Ron Victor, I've misspelled his name here, the late Ron Victor ran these series of experiments initially in Dallas and then in LA, but using Black barbershops to control blood pressure. And here's a group that is at high risk. They have historically underutilized healthcare in the traditional settings. They have a very trusting relationship with their barber. The average relationship, Mercy, I don't know if you know, the average relationship in this study between the men and the barbers, 10 years. These were deeply trusting relationships in which, like, they put the pharmacist to help with their blood pressure control, right? So rethinking not just how we deliver care, and I'll come back to this idea. We dealt with a situation like this when the COVID vaccine first rolled out in Boston, where there was a question of church-based COVID vaccine delivery. And I'll talk about the economics of that at the end of our talk. But very much, these innovations care delivery are going to be important because they're meaningless. All of our new molecules are going to be useless if we can't afford either the cost of the treatment itself or the cost of delivering this treatment. And here I want to emphasize that we traditionally think about treatments as drugs or devices, and those are expensive, but implementation costs can also be pretty substantial when you're thinking about things like blood pressure control or screening for familial hypercholesterolemia, for instance. And I'm going to give you some examples from pharmacoeconomics, and you will see that the idea, again, I'm talking about drugs here, but you could talk about devices, you could talk about other innovation, which is that innovation is, we've kind of become so obsessive about innovation that we've made this economic shift to saying we're willing to pay vast amounts of money for something that's innovative. So the average drug price in the US for new drugs entering the market is now $180,000. Okay, so like average annual drug price. And I'm talking about averages. So you see the range on the right, it's like pretty substantial. And so we've gone from a short period of time from a $2,000 drug being considered expensive to now $180,000 being the norm. And this is completely outpaced both the general economy that is growing at about 1.6% per year, and we'll see how that fares over the next few months, and versus the list price that is growing at 9% a year over this very long period, right? A period of 11 or 12 years. So we're not talking about individual bumps. Even the net price, meaning price net of discounts, is growing 4.5% per year. And in fact, if you look now, it's going to be even greater because the discount rates are likely to fall. And And so what that means is that for innovative drugs, again, I'm sticking with the economics of innovation here, for innovative drugs, for exactly the same molecule, we pay $100 for which our neighbors pay, or our peers pay a lot less. And so on average, prices in the UK are a third of what we pay. And in about Brazil pays a sixth of what we pay. India pays about a 20th of what we pay. That's like the back of the envelope for brand name drugs. And these have real implications. For our number one drug from the last couple of years, semaglutide, we're paying about $1,300 between 900 and $1,300 a month. Whereas our peers are paying in the 200s, 300s a month, right? And so the entire conversation about how you use this drug changes if the pricing it looks that different. So the point I've made so far is our healthcare system is in trouble because the current trajectory of healthcare spending is not sustainable, that the only way out of it is to innovate, and innovation has taken many different forms in the last decade. But innovation for innovation's sake is not going to be enough. We have to figure out how to pay for this innovation. And currently, there's no self-regulation in the system, right? Like the innovators are extracting rent, as it were, for being the brightest, newest thing. And we have to be able to figure out how much we should be paying for this innovation. I'll take one other side note here, which is that so far I've only talked about the total cost of innovation. Here's a drug, it costs $180,000 a year. A separate piece of that is how much are the patients paying for themselves. And so out-of-pocket costs, of course, are a major barrier. And I'll bring you this first case study, which is the PCSK9 inhibitors. Now, PCSK9 inhibitors were these two biologic drugs that were approved in 2015 to lower cholesterol. And when they first entered the market, they were considered blockbuster drugs. You could not go anywhere in the cardiology world without seeing an ad for a PCSK9 inhibitor. I remember going to cardiology conferences and my hotel key card had a PCSK9 inhibitor ad, yeah, because they were thought to be blockbuster drugs. They were going to change how we treat high cholesterol, and they entered the market at $14,000 per year, which was way more than any cholesterol drug had ever been cost. But they figured this is innovative, it's a new drug class, we're going to be able to get away with this. But what ended up happening is that the payers freaked out. And so there were onerous, there were delayed approvals, et cetera. And again, they expected for this drug to yield a very high return on investment in terms of their pharmaceutical expenses. But what happened in the real world is that plans decided they were going to pass a lot of these costs on to patients. Some of this is, here I'm presenting Medicare data, which was just the way the Medicare benefits plan was structured at that time, where essentially the 30-day cost sharing was about $300. Now, for contrast, like you could go to the pharmacy and get a statin for $1 to $2 a month, and then they were showing up for PCSK9 inhibitors and being told that their annual out-of-pocket costs were in the range of $5,000. But in reality, more than nobody was paying that because most prescriptions were going unfilled. So more than half the prescriptions were getting unfilled. There were denials by the payers, but also patients would show up and abandon these prescriptions. So we're like, I'm not paying $300 for my cholesterol therapy. And so here we had this really effective therapy that people couldn't get, not just because of the total cost, but because the out-of-pocket cost put it out of the reach of patients. And here are the data that if the copay were $0, nearly all got filled, but if the copay was over $350, nearly all got abandoned. Yeah, it was very much a correlation with cost. And the thing to remember is that out-of-pocket costs are, in our health system, almost unrelated to the value of the drug. So you could take, and even if it were related to value, patients are not able to tell them apart. So this was a really interesting study by some health economists, and they said they used the natural variation in Medicare out-of-pocket costs as a quasi-experimental design to say what was the effect of copay change on outcomes. And while I will tell you, I don't believe these results. I don't believe that $100 per month drug budget change increased mortality by 14%. There's nothing that we do that has that kind of signal, but I think it's directionally correct, which is that people are not making a distinction saying, well, my statin saves my life, but my skin cream I could pass on this month. They just show up and they say, which is the most expensive medication? I'm not taking that one. Or worse, if my total out-of-pocket costs are $50, I'm not filling any medications this week, even the one that cost me only $1. So again, we have to innovate, but we are going to have to figure out how to pay for it. And it's not just total cost, but also how much patients have to bear in terms of costs that is going to affect the population value of innovation. Which brings me to the most fun part of the talk, which is like, okay, now how do we agree that we have to figure out how much to figure out the value, but how do we do that? How do we go about figuring out the economic value of innovation? And the punchline here is that in order to determine the optimal price of an innovation, we have to clear a sense of what we're willing to pay for the value that this thing is generating for us. And this is a combination of quantifying the value and then clarifying our own values. Yeah. And I'm going to take some time to talk about this, because how a society allocates healthcare resources is as much a philosophical decision as it is an economic one. Now, this is obvious to all of us who spend time thinking about it. It's becoming even more obvious in the past 6 months that it's as much an economic decision as it is a philosophical decision. And I want us to take a minute to think about this. Of all the things in here, estimating costs is actually the easy part, right? Because how do you figure out the cost of something has been worked out, even though as clinicians and as researchers, often this is not a space we inhabit. Like, resources are consumables plus labor plus capital. And you figure out each of these buckets, and there are methods to figure them out. There are two types of methods. There are microcosting methods, meaning you actually follow a patient around and say, how much time did you spend with the nurse, and how much time did you spend with the doctor, and how much time did you spend with the pharmacist, and you add up those times. And so that's called microcosting. And then there's gross costing, which says, well, how much did the hospital get paid for that pneumonia hospitalization? It's close enough, right? So microcosting and gross costing. The cost is the easy part. The harder part is figuring out the value. Yeah. And here's where we're going to start with an experiment. Let's say you were traveling, let's skip Houston, make it Chicago. You're going from Chicago to Mumbai. My parents live in Mumbai. They're very cool. You want to go see them at least once a year. And here are your three options. You can go by ship, and it's $500, but it would take you 30 days. Yeah. If you could fly economy, and it's $1,500 and it takes you 21 hours. Or you could fly business, and it's $7,500 and it takes you 21 hours. I'm going to give you 10 seconds, not just to make a choice, but think about why you made that choice. Yeah. And obviously some of us will make different choices. So what would you pick? You're going from Chicago to Mumbai. These are your three options. And why? So why not why not any one of the other options? And if you're like me, what you're thinking is the following: that ship sounds cool, but I do not have 30 days to get to India, right? Like, I have to be back in 10 days. I'm not going to be taking that ship, even though it is the least expensive option. Yeah. So at the very least, if my choices were ship versus flying economy, I'm flying economy. And then if then you make the next set of comparisons, which is like flying economy versus flying business. And you're like, look, it's not a time thing. It's still 21 hours, regardless of how long, which cabin I'm in. And then your question is the additional $6,000 worth the 16 hours of comfort? And for many people, the answer is, I think I have better use for my $6,100, $6,000. And for some people, you might say, listen, I have a short trip. I want to show up rested when I show up, and I'm going to spend the $6,000. The point I'm trying to make is that economic evaluations involve pairwise comparisons. Because here's the thought experiment. What if flying economy were not an option, and your only option were to go by ship or fly business? You have to go. And these are your two options. What would you pick? And I bet for many of you, then the option would be, hell, that's not what I want, but I'm going to fly business because I'm going to spend the extra money I still can't afford the 30 days. And so your choice depends on the comparator. And so the point I'm trying to make is, in order to do a good economic evaluation, you have to have all the comparators on the table, because when someone artificially takes a comparator out or inserts a comparator that's not really available to you, you can end up with a different decision, possibly an erroneous decision. And the same is true for medicine. Like, if you're going to talk about blood pressure control, you want to put all the options on the table. If you're going to talk about lipid control, you want to put all of the options on the table. If you're going to talk about one step, you want to abstract out a step and say, I want to put all of cardiovascular prevention on the table. That's fair game too. It's answering a different question, but it's fair game. When you take options out or you insert artificial options, you get incorrect answers. But also the math that you did looks something like this, right? How much am I paying for the next available option, and what am I getting for it? So between the ship and the economy flight, you said, hey, I'm paying more for it, $1,000 more for it, but I'm saving so much time. And that ratio is worth it for me. And that's the incremental cost effectiveness ratio that we think about. And you said, that ratio makes sense to me. The next ratio up, paying $6,000 for flying in comfort, that did not make sense to me, because you have some internal threshold that you're using. In medicine, we've, over the past decade or so, 2 decades, we've been using a threshold called $100,000 per quality adjusted life year. I'm happy to answer questions about that. But somewhere in the range, actually, new empiric data is suggesting that our national threshold, as it were, is somewhere between $100,000 and $150,000. And again, as a reminder, the goal is to come under the threshold. Yeah, so 90 is good, 120 is bad. So that's how we think about value in the cost effectiveness literature. And here again, going back to that example of the blockbuster cholesterol drugs I told you about, they came in at $14,000, and we were like, okay, let's figure out what the incremental cost effectiveness ratio was. There's a model called the cardiovascular disease policy model that has been around for a long time, is very well calibrated to the US national population. And what we found is, big picture, if you give people who have high cholesterol these very effective drugs, it does good things for them. You have fewer major adverse cardiovascular events, lots and lots and lots of quality adjusted life years gained by preventing heart attacks and stroke and heart failure and all the things that come with cardiovascular disease, but it is going to cost a boatload of money. And I just want you, don't worry about the numbers, but focus on the order of magnitude. Because people will say, yeah, you're paying all this money, but think about all the money you're saving from averted heart attacks and strokes. And you're like, yeah, the averted heart attacks and strokes are going to save you money, but the amount of money you're spending to prevent these is an order of magnitude larger than the savings that are coming from strokes. And so you ended up with an ICER of about $400,000. Remember, our goal was to come in at under 100. So we missed by a lot with these drugs. And so we made the case that a 70% price reduction is needed to meet the traditional cost effectiveness threshold. Now, a couple of caveats here. Cost effectiveness is not the same as price, and that, again, is evident from the way we've done our math, which is like PCSK9 inhibitors, when they first showed up, they're expensive drugs, but they're not cost effective. You have something called a poly pill, which combines a bunch of generic cardiovascular agents that are like, it's very inexpensive, very cost effective. Give it to people, it reduces heart attacks and strokes. And then this last example is interesting. The Hep C drugs were super expensive and yet very cost effective, because it's a 3-month course with a greater than 90% effectiveness. And so you end up in a place where a high cost medication is cost effective. So again, I would encourage you to think about cost and cost effectiveness as different things, or price and cost effectiveness as different things. Cost effectiveness is also not the same as affordability. Something could be very cost effective and unaffordable. So budget impact is a function of number of prescriptions time unit cost. So part of the reason the payers were freaking out about PCSK9 inhibitors is that between 9 and 10 million Americans were eligible for therapy, for lifelong therapy. And so by most projections, if people got on this therapy, it was going to be a big cost. We're seeing the same story emerge with GLP-1 receptor agonists now, lots of people eligible for weight loss therapies. And their prices are lower. They're about $8,000, but so at that price, you're going to bankrupt the system. But remember what I said, like when we think about costs, we don't just want to think about the total costs of the system. You want to talk about patient costs. And in cardiovascular disease, it's important because patient costs can be very high. So until the Inflation Reduction Act changed the benefit structure of Medicare, about 1 million Part D beneficiaries were going to have out-of-pocket costs over $2,000 a year. And that's a lot of money for seniors. And so clearly you see that results in people falling off their medications. I put some examples here of like, you can see the more garden variety high cholesterol drugs is about $1,000 is $1,700 a year. But by the time you get to the more rare disease drugs like cardiac amyloidosis, patients were expected to pay $15,000 out of pocket. Now, you can clearly see that that is not something most of our Medicare beneficiaries can afford. And although what we've talked about, so again, the question we're trying to ask is, how do we evaluate how do we examine the value of innovation, the economic value of innovation? So far, I've given you examples of pharmacological agents, but you can also do this for care delivery. So that barbershop program that I told you about that Ron Victor ran, we ran this analysis, and this is how I first met Mercy, because you handled this manuscript for circulation. And so the point we're trying to make is like, look, Ron ran this small trial in Dallas and then in Los Angeles, but actually that model could be expanded to urban centers nationwide. And if you did, you would touch 1 in 3 Black men with hypertension. In that population, you could eliminate 40% of strokes. And as long as you could deliver this at less than $1,500 a year, it would meet a cost effectiveness threshold. Now, see, this analysis is flipped on its head. I'm not saying this is how much it costs, what is the cost effectiveness? I'm saying if you wanted it to be cost effective, how much would it have to cost? And so often for implementation, the reverse economic evaluation is useful. Even if you're proposing something new for Northwestern or for the city of Chicago, it's helpful to say, hey, if we did it under a certain price threshold, it would generate value. Then the second part of this is, I said, part of it is determining value, and the second part of it is determining values and clarifying our own values. And so here's a thought experiment. This is the last thought experiment of the talk, I promise. Amartya Sen is an Indian American economist who won the Nobel for his work on distributional justice, but like more on how societies distribute resources. And in his book, The Idea of Justice, he uses this example that I want to share with you. Imagine that you're out in the forest and you come upon 3 children. These 3 children are arguing over a wooden flute. Yeah, as to who should have the wooden flute. Anne says, I'm the only one who can play the flute. And Bob and Carla agree. They don't know how to play the flute. It's just like, well, then, I should be the one who should have the flute, because I'm the only one who can put it to good use. Reasonable? Seems fair? Then Bob speaks up and says, hey, I agree, I can't play the flute, but I'm poor and I have no other toys. Anne and Carla have tons of toys. So I should be the one who has the flute, who gets the flute. Reasonable? Maybe. Fairly reasonable. And Carla speaks up. And she says, I made the flute. I agree, I can't play the flute. I have a ton of other toys I can work with, but I made the flute, so I should keep the flute. Reasonable? Right? And so the idea that Amartya Sen is making here is that you can reason your way to different conclusions based on your priorities. So if you're a pure utilitarian, you can say, well, clearly Anne is the only one who knows how to play the flute. She's going to derive the greatest utility from this flute. And so she should be the one to keep the flute. If you're an economic egalitarian, you say, well, Bob is the only one with the one with the fewest toys. He should keep the flute. And if you're a libertarian, you might say, well, both those arguments are fair, but if Carla made the flute, she could keep the flute. And what this, again, the point he was trying to make is well-reasoned arguments can lead you to different conclusions. So just because you're disagreeing on your worldview doesn't mean that one person is right and one is wrong. And I'll skip to that last point there. It says it's not sufficient to build fair rules and institutions. What you want to focus on is the actual outcome and whether it aligns with your priorities. So if you're an egalitarian, you're focusing not on rules that create egalitarianism, but the actual achievement of egalitarianism. And in the present world, this middle quote is from Thomas Piketty. This book, he's a French economist. A Brief History of Equality is worth reading. It's a quick read where he says the world moves towards equality in fits and starts. Our economic world has historically over the last 400 years moved towards equality in fits and starts. But he says, what history teaches us is that if you're unhappy with the current system, it's not enough to bring about change. Change is necessary, but not sufficient, because what you replace the existing system with is extremely important and affects what the new world order will look like. And taken together, how do I think about this in my work? I say, look, in the end, we are a large and diverse country. We're going to have disagreements about how resources get divided. That is not a novelty. That is a given. If in this room of fairly like-minded people, I could give you an example of 3 kids with a flute and say, oh, I agree with each of them. You can imagine that we go out in the world, we have different worldviews. But part of it is then agreeing on not the perfect justice system, but like, is the next step we're taking creating more justice than we were before? Because perfect justice may not be achievable in a world where our definition of justice is different. All right, next question. When is the right time? Okay, so you've decided you have to figure out the economics of it. You need innovation because otherwise you can't deliver care. But you need affordable innovation, so we have to figure out how to value it. Now you've figured out how to value it, which is the incremental cost effectiveness, et cetera. You then line it up with your own priorities as a country or as a health system, some mix and match of libertarianism, utilitarianism, egalitarianism. And the question is, okay, now it's time to act. But when is the right time to use these data, to generate these data and use these data? And the point is that perfect timing for an economic evaluation is tricky because early in the life cycle, you have the potential to influence pricing, right? Like early on, I can say, hey, this drug is cool, but not that cool. I'm not paying $8,000 for it. But you don't have long-term data. You don't have data on safety. You may not have all the data on effectiveness. On the other hand, if you wait 5 or 10 years, you'll have perfect data on which you can base your models, but the price and use patterns are already established. And I see this in cardiovascular medicine all the time, where if I go back and say, you know, that cool drug you've been using for 10 years, it's really not worth the money, my colleagues are going to laugh at me. They're like, hey, we use it anyway. Like, I'm not, the pattern, that practice pattern is well established. We're not going to change that pattern. So when is the time? And I'll tell you this, I put this on a slide to make it a theoretical argument. This is the bane of my existence because I write a cost effectiveness paper and send it out to reviewers, and reviewers are like, this should wait another 2 years before we have more data. And 2 years later, I send it in and I was like, why are we doing this now? This, you know, this price pattern is already set. But so often, you know, well-done cost effectiveness analysis is used to feel a little bit like post-mortem analysis. Like, yes, we know everything, but the patient has passed, you know, like that kind of situation that the pattern has been established. And the way I've started to think about it is like, it's lessons from IKEA. Now, if IKEA is designing a bed, let's say they want to design a new bed, they have the price as one of the design constraints. It's not like I'm going to design this bed and then I'm going to figure out it's $800 and figure out who to sell it to. The designer gets upfront this idea that this should cost $200 or less. So like the economic considerations come in early. And the same is true for innovation, which is that economic considerations need to be part of the design of the innovation, right? Like there used to be this adage that there are more pilots in implementation science than there are in the American Air Force. Because you design these studies where you know that even if they're remarkably positive, there's no way to scale this high-touch intervention that involves 17 phone calls and 18 visits to control the patient's blood pressure. It doesn't work like that, right? So if economic constraints are part of the design, we'll get along further. On the flip side, as more information comes along, you update your economic evaluation, right? So for a drug, it might be there's new effectiveness data, there are new safety data. You can then update your evaluation and say, oh, by the way, we should be willing to pay more or less for this therapy based on this new information. And so an example here would be for GLP-1 receptor agonists, which are the Wegovy's and Ozempics of the world, we could say currently we're willing to pay a certain price, which is probably in, the price similar to the left, where the price in Europe. But in the future, if there are fantastic new data showing that GLP-1s, I don't know, make us prettier, where you can move this up and down, this scale, and based on information that you have about this therapy. So rather than thinking of them as like one time, I have one shot to evaluate the economic value of an innovation, we should be willing to update this over time. Okay, coming to the last part of the talk. So we said healthcare is expensive and broken. We've got to innovate our way out of it. But in order for innovation to work, we have to know the economic value. Here's how you do the economic evaluation and how you measure the value of this technology. What are the downstream benefits of doing this? And I'm hoping this part is helpful to trainees and members in the audience, but thinking about economic evaluations of your own work or your own interventions. There's lots of upsides to understanding the economics of interventions we do. It can guide pricing and improve access. It can guide implementation at scale. And in doing so, it can advance population health. And I'm going to give you a couple of examples. So for PCSK9 inhibitors, we kept updating our cost effectiveness analysis. And we basically said, every time they published a new paper, we updated our analysis and said, this is great, but your price is wrong. You need to come down. And one of the remarkable things about PCSK9 inhibitors is the companies finally relented. And they said, we're actually going to reduce the price by 60% of these therapies. There were two manufacturers, both of them reduced the price by 60%. In fact, we worked with one of them to help them identify what the range should be. We said 70%, they settled on 60. But here are the intermediate term consequences. So this happened in 2018, 2019. So we're about 5 years into this experiment. PCSK9 inhibitor prices dropped from 14,000 to 6,000. In fact, with discounts now, it's about in the 3,500 range. So really remarkable drop in the price of the drug. We have new data showing that this resulted in a decrease in out-of-pocket costs for patients from 5,000 to 1,600, and now slightly lower than 1,500. But more importantly, the new price has anchored the field, so that now the new drugs that are coming along are anchored to this new lower price of the therapy, right? So like we've kind of shifted the expectation on what cholesterol drugs should cost. And we have a paper in preparation that says for Medicare alone, this price reduction is saving $825 million a year, yeah, for Medicare alone. And Medicare is about 60% of their market. So presumably, this has caused a total disruption of this market for a decade. I will say that that is not how it always goes. We were helpful in moving this conversation along. There are other agents that I actually had that top analysis was with Dr. Sanjeev Shah here at Northwestern, where we said there's this expensive drug. It has no hope in hell of meeting its cost effectiveness threshold. Price needs to come down 90%. 5 years later, nothing has changed. Right? The price is still where it was. There was no price change, primarily because there's no competitor to this drug. And so there's no negotiation power. In the end, pricing is about negotiation. For the cholesterol agents, people were voting with their feet. For this drug, they've decided to not. So the price has not changed. I'm going to end with one last example of why knowing the economics of innovation can be helpful, both in terms of implementation and in terms of health equity. And this comes from January of 2021. I'm going to take you back to Jan 2021. we've gone through a bludgeoning pandemic, first year of the pandemic, which I remind you that in Boston was very brutal. The first wave was very brutal. And the vaccine arrived in December. By January, all the healthcare workers and were vaccinated, and now the plans are underfoot to vaccinate the rest of the city. And I said, well, there were two questions that needed to be answered. One was if you remember, the federal government was saying the vaccine is free, you can deliver this voluntarily. That was the original plan, that volunteers will deliver COVID vaccines. And so we built this model and we said, actually, the cost of delivering this vaccine is so enormous that states are unlikely to be able to deliver this vaccine without support. Right? And this was that idea that even when the cost of innovation of the strategy itself could be zero, but the implementation costs are substantial. But on a more local level, there was a question about whether it made sense to have vaccines. So we were delivering vaccines now mostly through the hospital. And there's a synagogue across the street that was delivering vaccines. And there was an option of putting a vaccine center at a church in a Black neighborhood in town. When you do the unit cost analysis, it was much cheaper for us to vaccinate in the hospital because we could vaccinate 100 people an hour. You remember that first vaccine, you had to have 15 minutes of monitoring time. And so people were sitting around for 15 minutes. And so all of that we could do at scale in the hospital for almost no money. There were like lots of volunteers willing to spend time and do this. Across the street at the synagogue, costs were higher, but we were still vaccinating hundreds of people an hour. At the church, we were vaccinating far fewer people. And so when you think about a nurse or a pharmacist who has to be there all day to deliver this and monitor individuals, the per person cost of delivering the vaccine at that church was much higher than in the hospital. And so if you just thought about the cost, as many health system leaders do, you would say that is not a good use of our money. Yeah, but you know where I'm going with this, which is that the per vaccine, given the distribution of COVID-related complications in 2021, vaccinating an individual in that community had far higher returns than vaccinating individuals in the kind of people who were coming to the hospital for their vaccines. And so when you go from thinking about costs to cost effectiveness, you automatically made the case that that church-based vaccination program was likely to be highly cost effective. And it's my way of sharing with you this idea that you were focusing the cost, like the idea of focusing on cost effectiveness was not at odds with advancing health equity. In fact, using the cost effectiveness argument was a way to ensure that that church-based program continued for as long as it did. And so I would encourage you that for those of you who are working broadly in implementation science, but particularly in health equity, you think about the economics of the interventions we're studying, because they actually will substantiate or bolster your case to invest in equitable population health interventions. Again, examples of this, there are so many examples in GLP-1s, et cetera, where making them available, even though they're high-cost medications, making them available to high-risk populations is invariably both efficient and equitable. And I'll close with this quote from Thomas Piketty, which is that inequality is, first of all, a social, historic, and political construction. For the same level of economic or technological development, there are always many ways of organizing a property or a border system, a social and political system, or fiscal and educational system. These options are political in nature. In the end, resource allocation is a political question. It is a question of priorities. It's a question about our values as a society. So economics doesn't get us all the way there, but it at least forces us to be explicit about the values, because then we can have a transparent conversation about why we're doing the things that we do.
Well, thank you, Kazi. That was a really interesting talk, very thought-provoking, and we really appreciate it. Thank you.